Thank you very much for that presentation. I'd like to invite Nancy and Gabriel to turn on your videos, and Joe, Manuel, Mitchell, and Gary to the front of the table for the panel discussion.
Everybody getting settled okay? Maybe I could ask the first question, realizing that we only have about 10 minutes for the discussion, and also thinking forward that, tomorrow we want to actually have some steps forward, things that we can recommend for the future. So we heard terrific talks, each of you bringing your own perspective. And I'm wondering whether each of you in like one sentence or two could tell us the thing that you think we need to do right now from an academic perspective, of course, that would allow us to deliver on this vision of precision or integrated diagnostic based on your experience and on what you've heard from each other today. And Kojo, you're in the room, so maybe you could go down the panel three.
Yeah, I'll start from the end of the table, Manuel.
Thank you. It's early days in integrated diagnostics, and the examples that we have are very modest. And we still don't know how to integrate large cohorts. To me, there is something I could do academically is to encourage significant and specific investment in this area. Now, I think that for that, we need to be very careful of how we define this. But I think that in a research and development academic space, this is what I would ask for, significant specific funding in this area.
Thank you for that. Joe?
Thank you. I believe the diagnostic field has moved through the phase of manual diagnostics to technology-driven to data-driven, and the question is, of course, what's next? So slightly reframing your question, what needs to be done next is, in my opinion, a full-on and active embracement of regulatory science. I think active engagement with the regulator, actively influencing the regulatory and governing paradigms. What I believe several of the speakers have mentioned is there's strength in radiology, the clear paradigm, the inability of radiologists to fully integrate AI based on their premises using their own data and performance metrics is, I believe, one of the key limiting things, and that is a regulatory science question that can be solved with data and active engagement with the regulator. Thank you.
Thank you. Mitch?
There you go. The number one thing that we can do is partner. I think that if we really, align around this vision and work together as opposed to cross purposes, I think we can move the needle. And it's not just amongst academic programs, but academic programs, commercial enterprise, and regulators and payers. We all have to partner together.
Gary?
Well, I'm going to approach this from a slightly longer-term perspective. I think we need to train the next generation of radiologists and pathologists and perhaps geneticists and others into this model. We won't be able to truly integrate until we have people who understand the entire landscape. I came into this area very late. I was an MR physicist and an engineer for most of my career, and Sam really inspired me to look at this and think about this. But I'm never going to be a cancer biologist or cancer pathologist. but I think the next generation of scientists and clinicians could be much more able to talk to each other, I guess.
The points made are very well taken. We have two questions, Sorab and then Charles.
Could Gabriel answer that question before we move on?
Yes, thank you. Thank you. I was eager to answer. I think we thought, at least I have been involved since many years, as you have seen in this topic, and we thought that adoption will be easy because it increases efficiency, increases quality, and decreases costs. But it seems that these arguments are not sufficient. So it has to be additional added value. And I think many of the solutions that have been presented by my fellow panelists, the data integration and an added value through analytics, something that we humans probably are not able to do, that will be, for me, the key for the solution for the coming years. Thank you.
If I might just dovetail on that comment, ultimately, there needs to be incentivizing behavior. And I think the alignment of the incentives is what's going to drive the behavior, because most of the discussion has been actually the social engineering. Because a lot of the technology and the inputs, it doesn't matter how diverse they are, like some of the examples that Gary gave, those will continue to diversify. But if there's resistant behavior and nothing to incentivize behaving differently, we're going to remain where we are. So I'll just recognize on the floor two questions from Sorab and then Charles.
Hi, Saurabh Shah, Memorial Sloan Kettering. Thanks again for the session. This is a question for Dr. Gould. I was struck by the innovations that are presented, the smart toilet, the wearables, for example. So we're all struggling with even data that's procured in the provision of care within our hospital systems to integrate at that level. Do you, or anyone in the panel, envision that these types of sort of at-home data collection devices will ultimately be the domain of large technology companies, and how will hospital systems or healthcare providers actually access that data? Because ultimately, these are data collection devices that are invested by venture capital as a route to just get data from individuals and then commercialize through various routes. And so I'm just curious on your perspective, how do we bridge that divide?
Thank you. That's a great question. Before Sam passed away, he established a new center called the Precision Health and Integrated Diagnostics Center that I co-direct with Joe DeSimone at Stanford. And the idea is really, really long reaching, far in the future. We want to detect disease at the earliest possible point and keep people healthy through, for example, if you flew here on a jet plane, the engine on that plane was monitored thousands of times a second for the first signs of failure. The idea is to transform our healthcare system into a system that monitors people, detects disease at the transition from health to disease, and treats it at that earliest point when it's most likely to be effectively treated. Now, this is a very, very long vision. There are many obstacles, payers, companies, regulatory, privacy, as you noted. I do think, though, we're starting to see more and more of this kind of creep in to our healthcare system. I have lone AFib. I check my Apple Watch when my heart feels off, and it tells me whether I'm in AFib or not. So this is coming for all of us, and I think the sooner we can get our own house in order and as Mitch said, work together, the better off we'll be to be able to integrate this tsunami of digital data which will be coming.
Thank you very much. Manuel, did you want to say something?
No, I totally agree. I think that the question of the accessibility to large data is a big one, and certainly when it's in the hands of venture capital is difficult. When it is generated by government funding, I think that's when I think the logic should prevail, and the availability should be as open as possible.
Just to mention that at the population scale, we can see what A, direct-to-consumer marketing can do, B, how transformative it can be in healthcare based on our current situation where I'm 100% certain everybody has done a home COVID test, willing to sacrifice sensitivity and accuracy for just knowing your positivity status and that modifying your behavior, which ultimately is what we want to get to. And somehow we found a universe where industrial interests, corporate interests, government, public interests aligned with an outcome that was beneficial to everyone. So I don't see a universe where there'll be one solution. There'll be a concatenation and collaboration of solutions that yields an end product that we're all satisfied with at some point. Charles, you get the last.
Hi, Charles Sawyers from Sloan Kettering. So I really enjoyed the session, and I want to give my perspective on Nancy's challenge for what's an action item by close of tomorrow. And I have been involved in projects sort of like this where you need to break silos. And there's nothing like a good use case or an example to successfully execute and then motivate people to follow. And Mitchell, when you made that sort of comment in passing that you thought the incidence of reoperation for breast atypia would go down, that resonates with me as the kind of sort of pilot that could really make a difference. So I would just sort of challenge all of you over lunch maybe to brainstorm.
Thanks. Great comment. So this would conclude panel one. I see the time telling us we're about 30 seconds over, and we'll start panel two. I'll thank the panel members very much for their participation.
Thank you.
Thank you.